So the iatrogenic complications are techniques employed for anesthesia which can produce iatrogenic complications can be classified as complications that can occur because of general anesthesia, and regional, which again can be classified into central industrial blockade and peripheral blockade. So this is how the first thing you can give the subheading for this answer. And the duration or the time at which these complications happen can be classified as pre, intra, and post-op periods. So we first define these two things, and then pre-op complications under general anesthesia or regional anesthesia. The common complication is failure to see the patient in advance before surgery, which may be because of laziness or the nature of the surgery is patient, for example, an emergency LSCS, category 1 LSCS, where there is a life-threatening situation for both mother and fetus. You have hardly any time to examine the patient's airway, spine, and all those things, and patient is wheeled in. So that may be the reason why you don't do a proper pre-op evaluation, or too much of overconfidence and negligence that you can manage any situations. That sort of attitude is also there among the anesthetists, which is the reason for the iatrogenic complications to happen. So this can result in not knowing the patient's comorbidities, their current status, medical history, allergies, etc. And that can be the cause. Then failure to review the investigations in detail. For example, you prescribe, you hear a murmur, you ask for an ECG and an echo, and if you don't review that and find out what is the cause of the murmur, you will be missing a vital irregularity, and that may be the cause for the iatrogenic complication that is being produced. So this is the second reason in the pre-anesthetic or pre-operative state. And lack of detailed airway examination, which leads to failure to notice a difficult airway. So that will end up as an unanticipated difficult airway because we have not examined the airway properly. And failure to locate the proper venous access, especially in pediatric patients, the children who are chubby. Sometimes the IV line access will take more time than the surgery. For example, a very chubby child who weighs about 10 kilos at the age of 6 months coming for a circumcision. There are incidences where anesthetist has taken 1.5 hours to locate the vein and surgeon finished the circumcision in 15 minutes. So that sort of complications are also can possible. So it is always better to locate the venous axis, one to prevent multiple attempts as well as to identify where you can have a good access and secure it at the earliest. And failure to look at associated congenital anomalies, especially in pediatric cases, this is one of the important reasons for the iatrogenic complications. And in female patients, always, especially who are in the reproductive age, ask for the due date for menstruation, especially in elective surgeries, so that sometimes the surgeries are postponed not because the patient will have any coagulation or bleeding problem, but it may cause more discomfort to the patient if they have their menstruation cycle and then abdominal surgery together. So this is the reason, this is another thing which we have to take into consideration. Then failure to give proper pre-op instructions about investigations and medications, especially with the drugs like hypo or hyperglycemic drugs, hypertension, and thyroid drugs. These are all the drugs which we have to give proper clear-cut instructions, which may lead to the patient taking or not taking the drugs and producing problems because of that. Now, coming to intraoperative problems, you can classify them under general anesthesia and regional techniques separately. So, failure to do a proper machine check. This is the most important thing which has to be done every day and before every case, so that you don't land up in any, especially hypoxic insults are not produced by not noticing the oxygen supply. Failure to select proper size mask, airway, laryngoscope blade. If you are planning to do a intubation, all these accessories should be correctly checked, and so that you have a correctly fitting size face mask, especially when you are doing a pediatric case. Having a 3 size mask with for a 1-year-old baby, you will end up with a lot of problem of not able to ventilate properly. So that is the second important thing. Third thing is checking the doing a proper technique in laryngoscopy to avoid injury to lips, teeth, gum, tongue, and pharynx and larynx. And improper mask ventilation leading to distension of stomach, especially in children, due to ill-fitting mask or a high flow, which is unnecessarily needed, used for ventilating the patient, which may result in the possibility of immediate post-op or intra-op vomiting and aspiration. And unnecessary use of oxygen flush in case you have a difficult intubation and the patient starts desaturating. Then many people, as a reflex, we will apply the mask and use the oxygen flush to ventilate the patient. This may lead to barotrauma. So this is another iatrogenic complication which you have to avoid. And failure to recognize the esophageal or endobronchial intubation. More than esophageal, most of us will recognize. And nowadays with the ETCO2 monitor, we can see a flat line or not a proper graph coming. So we can easily recognize the esophageal intubation. But endobronchial intubation, especially during the learning period, in your enthusiasm to pass the tube through the vocal cords, you push the tube too much inside, especially in pediatric patients, which will go into the right bronchus. Left bronchus will not get ventilated properly. The same thing can happen in obese individuals with a short neck also. So conventionally, for a adult female, you think 20 or 21 at the incisor level will be the ideal length inside the trachea. But 10 days ago, I had to go and help a patient who was obese for abdominal hysterectomy. And the junior anesthetist who was there, he said, "Sir, I am keeping it at 21." And when I auscultated, there was no air entry on the left side at all. Then I showed him that there is no air entry. And ultimately, when we gradually pulled out the tube, at 18 centimeters only, we could hear the air entry equally on both sides. So don't go by the regular value that it should be 21 or 20. Always auscultate and make sure that it is equal. Air entry is equal on both sides is very, very important rather than the number at the incisor level, especially in short necked and obese individuals and pediatric patients. And this is the common cause for gradually accumulating CO2 and hypoxemia and collapse of the lung in the post-operative period. And, so this is a very important iatrogenic complication which has to be prevented. Similarly, traumatic intubation leading to bleeding and aspiration of blood, especially in patients who are anticoagulant drugs. So what we had discussed in the last question. So anticoagulation can be sometimes troublesome for patients undergoing GA also. And especially when you anesthetize a patient for open heart surgery and patient is going to be on cardiopulmonary bypass, where they will be heavily anticoagulated with heparin, your intubation, which has caused the bleeding, which would have stopped by the time you start, will reactivate and get more bleeding when the patient is heparinized. So your technique should be so correct and non-atraumatic so that you don't land up with a bleeding after the patient goes into the bypass. And laryngos and bronchospasm due to instrumentation and inadequate induction of anesthesia, or in a patient with reactive airway, which can all lead to hypoxemia. So we have to be very careful in inducing a patient with a known COPD or a reactive airway like a smoker. and you must induce the depth of anesthesia correctly so that when you do a laryngoscopy or intubation, you don't land up with the problem of laryngo and bronchospasm. And placement of IV access, especially in the AV fistula limb in a patient with chronic renal failure who is coming for a non-transplant surgery or transplant surgery, you must avoid using the BP cuff or the IV access in that particular limb. And failure to select the appropriate size cannula, which we may give difficulty in if you need to give a blood or a colloid fluid, that may be, for example, if you use a 22 gauge cannula in an adult and try to give transfuse blood in an emergency, you will hardly find the blood flowing at a required speed that we need to transfuse. So you must plan your cannula size also appropriate to the surgery and anticipating the blood and fluid loss. And wrong drug administration due to failure to label the syringes or administration of inadequate or excess dose, especially which can happen in pediatric cases. When you do a child which is less than 10 kg weight, unless you dilute the drug to the correct concentration and administer, you can always land up with the excess dosage. And overhydration or underhydration, which may lead to hemodynamic instability, and failure to monitor blood sugar and electrolyte in patients with uncontrolled DM during emergency procedures. This is also an iatrogenic complication. Failure to monitor temperature during GA, leading to hypothermia and its consequences, which we just now saw in the form of shivering. Failure to monitor urine output, leading to either fluid overload or acute kidney injury. And failure to provide eye protection, leading to corneal exposure and ulceration. And not properly giving padding covering to pressure injury sites like the elbow or the lateral aspect of the knee, etc. Failure to apply monitors properly at the beginning of surgery, leading to disruption of signals during critical times of surgery. So when we put the ECG monitor, majority of the times, they don't stick properly, or the hair in the chest in male patients will distort the signals. So in a major surgery where you want a correct monitoring of the cardiac function, you have to make sure that all the monitors are properly applied. And the vascular lines and monitors should be properly secured when you want to change in position. For example, when you want to change from supine to prone position in spine surgery, make sure that all the monitors and vascular lines are secured properly so that you don't have to restart or refix it after changing the position. And failure to inform the surgeon in time during development of unanticipated complications like malignant hypertension or thyroid crisis, air embolism, or anaphylaxis. So always be in communication with the surgeon and inform them about all these changes. Inadequate analgesia leading to intraoperative tachycardia, hypertension, which may lead to either cardiac or the CNS complications later on, especially in patients with MI or myocardial ischemia and the pre-anesthetic level. Failure to assess muscle paralysis whenever you give the neuromuscular blocking agent, which may either cause an inadequate dose leading to bucking and coughing on the EP tube, especially in neurosurgical patients, which may result in raised ICP, which will be worsening the condition. And failure to provide correct depth of anesthesia, which may result in awareness and result in post-traumatic stress disorder or unnecessary unpleasant memories. Coming to the post-op complications, failure to take steps to prevent vomiting and regurgitation during recovery, failure to assess the muscle power before reversal, and hastily extubating, which may result in residual muscle paralysis and hypoventilation in the spider or obstruction to the airway. Failure to provide analgesia intraoperatively, leading to a very restless and violent recovery, especially in pediatric patients. If your intraoperative analgesia is not there, children come out crying, kicking their legs and feet, and failure to prevent shivering due to inadequate measures taken during intraoperative period, and failure to identify patient restlessness due to full bladder or catheter irritation after TURP, and all patients who are likely to be catheterized should be informed before induction of GA. I make it a routine practice to tell the patient before I induce that they will have a tube in their urine passage, and that may give a feeling that you may want to pass urine. You can just pass it because it will go only into the bag, and if you tell them, they politely accept that, and the restlessness because of the catheter will be very much reduced. And the proper steps to be followed during shifting of patient, especially obese patient, to prevent fall, which again can be a iatrogenic complication. Now the complications under central neuraxial block, all these things we have discussed so far belong to GA. Failure to position the patient properly for especially in spinal, either single shot or epidural, we must position the patient properly. And failure to ask for help when you are not successful after 3 or 4 attempts. Going on trying by the same person will be quite cumbersome to the patient. So you can definitely let go your ego and ask for help from some seniors or more experienced person to avoid discomfort of the patient. And inadequate pre or co-loading leading to acute hypotension after a subarachnoid block. Not keeping the emergency drugs ready in case of resuscitation and leading to sustained hypotension and its complications. Failure to prevent intraoperative shearing by both pharmacological and non-pharmacological methods. And PDPH due to large size needle or accidental dural puncture during epidural, which is also considered as a iatrogenic complication. Now, failure to inform patient about noise pollution during surgical instrumentation. This is one of the things which is very common in orthopedic theaters when they use the drill and hammer and chisel and all those things. Patients get frightened because under regional technique they will be listening to all these noises, and then they may get agitated at the post-op. So it is better to inform them or make arrangements that their earplugs are put in and this noise is avoided so that they don't get agitated or worried about it. And failure to protect the patient from radiation hazard using a C-arm or X-ray. Failure to protect patient from electrical burn injuries due to improper placement of wet pad or cooling of antiseptic liquids to after preparing the skin. And prevent the patient from watching the surgery by the reflection on the OT lamps, leading to apprehension and tachycardia and hypertension, and especially in regional technique, spinal or epidural. Failure to avoid unnecessary conversations, creating a sense of insecurity in the patients. So, you know, some surgeons and anesthetists have always the habit of conversing about the movie they saw, the party they attended, and patient thinks I am lying here for my saving my life, and these doctors are joking and talking in a careless way. So that may lead to even sometimes medical legal problems also if something goes wrong. And peripheral nerve and plexus block complications, failure to follow proper aseptic precautions, which may lead to infection, and not calculating the dosage correctly on body weight basis with chances of overdosage, and failure to avoid or recognize intravascular or intraneural injection immediately to prevent complication. Failure to monitor the patient during the administration of the block. So always put the monitors on, listen to the pulse oximeter rate, because once you are using a local anesthetic with adrenaline and even a small amount goes intravascularly, you will have an increase in the heart rate. So that it should itself caution you that something is wrong, and you must immediately check your again re-aspirate and make sure it is not intravascular. And failure to keep necessary emergency resuscitation drugs and manage anaphylaxis or the local anesthetic toxicity. This is also another important iatrogenic problem that we can create. And performing block on the wrong side, using a catheter for continuous analgesia, which may be used for infusion of IV fluids rather than the local anesthetic. So this mistake is commonly happening, especially when you give a continuous peripheral plexus block like brachial plexus in the neck, and that may be thought of a central line, and people have connected IV fluids instead of using it for continuous infusion of local anesthetic agents. And so these are the iatrogenic complications which I thought will be useful. Okay.
Yes, sir.